Good morning, everyone, and thank you for joining us today for our diabetes work group. Chelsea Andrews and I are the site engagement coordinators for MVC, and we look forward to facilitating this work group today. So for today's presenter, in recognition of National Kidney Month, today's work group will feature a presentation by Mary Wozniak of the National Kidney Foundation of Michigan, an organization that aims to prevent kidney disease and improve the quality of life for those living with it. Mary Wozniak is a senior program specialist at the National Kidney Foundation of Michigan. She received a bachelor's degree in public health education and Spanish from Central Michigan University in 2005. She earned a Master of Public Health degree at the George Washington University in Washington, D.C. Mary has over 10 years of grants management experience. Mary worked at a community health center in D.C., promoting early detection of breast and cervical cancer and providing nutrition and diabetes education to uninsured immigrant communities. While living in Peru, she provided monitoring and evaluation support to USAID-funded health and education projects. She expanded programs for integrated behavioral health and substance use treatment and Unity Healthcare at Unity Healthcare, a federally qualified health center. Mary has led quality improvement initiatives supporting clinical teams to increase depression screening and achieve remission for patients with depression. At National Kidney Foundation of Michigan, she supports health systems to improve screening for chronic kidney disease and to integrate clinical decision support tools to optimize care for patients with chronic kidney disease. Thank you, Mary, for joining us today for this work group. And before you begin your presentation, I have some brief housekeeping to review. So like I had mentioned, this session is being recorded and the slides and the recording will be shared with the attendees following the work group today. For any questions, we will be monitoring the chat throughout the presentation, so please feel free to add questions there, and we will have a designated Q&A at the end of Mary's presentation. Lastly, your feedback is very important to us, so please complete the post-work group survey. A link will be provided in the email sent following the work group that will contain the recording and slides of Mary's presentation. And with that, you're welcome to share your presentation, Mary. Thank you again for being here with us today.
Sure. Thank you very much for having me. Okay. Hopefully you can all see the screen now. Like Christy mentioned, I am a senior program specialist with the Kidney Foundation of Michigan, and I'm here to talk to you today about a significant public health issue of chronic kidney disease. So these are our learning objectives. First, we will discuss some of the risk factors, which of course includes diabetes, which is what we're all focused on here today, and then some of the health inequities that we find around chronic kidney disease. We will explain the 2 screening tests that are needed to diagnose CKD and also the HEDIS quality measure that goes along with that. And we'll learn strategies for managing CKD to slow its progression. We also have some educational materials to share with you and information about some programs on chronic disease self-management. So why are we concerned about kidney disease? One, it has a silent onset. You don't really have symptoms until it's at a later stage of disease. So we find that about 90% of people with CKD are actually unaware of it, but it is a very significant public health problem because of the morbidity, the quality of life that's impaired, and the shortened life expectancy. And in particular, it really increases the cost, especially for Medicare patients. CKD costs about $87 billion to treat, along with end-stage renal disease. So if you think dialysis and transplantation costs, that's another $37 billion. In Michigan, there's over 1 million people with this disease. That's 1 in 7 Michiganders. But again, many of them are not aware because we're not always testing for it. this slide shows us some of the risk factors for CKD, the most prevalent being diabetes and high blood pressure. 1 in 3 patients with diabetes will get some stage of chronic kidney disease, and 1 in 5 with hypertension. Fortunately, there are some modifiable risk factors that we can control for, such as controlling frequent NSAID use to not damage the kidneys further and not cause acute kidney injury. The non-modifiable risk factors are family history of kidney disease, being older, ages 60 and older, and certain ethnicities are at higher risk. So this slide shows us a breakdown. Of course, folks who are a bit older, 65 or older, are at much greater risk of having CKD. Women are slightly more likely to have it than men, and it is more common both for non-Hispanic Blacks and Hispanic Americans. There are several different causes of CKD and end-stage renal disease. You can see this broken out by age groups. So for the older ages, you see more diabetes and hypertension as the primary cause of ESRD. For Hispanic Americans, it tends to be because of diabetes. But for Black Americans, there's a much greater percentage due to hypertension. It's also important to point out that there's a relationship between CKD and COVID-19. With the COVID-19 epidemic, we found that people who have CKD are more likely to have complications from COVID, as well as people who get hospitalized with COVID-19 can experience a kidney injury, an acute kidney injury. And those injuries put people at greater risk of developing CKD later on. So just wanted to point out that relationship. So we're going to look at a patient scenario, kind of a common thing that we don't necessarily find CKD during the silent progressive stage. This gentleman is college educated. He runs his own company. He's been seeing his doctor frequently because he's diagnosed with diabetes and hypertension. However, he doesn't get diagnosed with CKD until he starts developing some symptoms for it. And then at that stage, it's about 6 months on average that people go before they have to start dialysis or kidney transplant to survive. And this is the majority of CKD patients that we're not finding early. This slide is a little busy, but the blue bars indicate the percentage of the population who have the different stages of CKD. So you see stages 1 through 5. 5 is really where you're going to see people starting on dialysis or transplant. But there are a lot of cases that we are missing. The red is the actual diagnosis. And then you see a sharp drop off here from stages 3 to 4. Now that is not, unfortunately, that's not because people are not progressing from stage 3 to 4. It has more to do with mortality from cardiovascular disease because there's a very strong relationship there. So there's a lot of potential both for cost savings, for saving lives by really focusing earlier on and detecting this disease at an earlier stage to be able to prevent its progression. CKD is diagnosed using 2 laboratory tests. The first is a blood test, the eGFR, and that provides insight into the overall kidney function. This is a pretty common one to be tested because it's part of your BMP testing. And then there's a urine test, which is sometimes missed, the albumin to creatinine ratio. This provides insight into the extent of kidney damage. So even if your eGFR looks normal, you can have early signs of kidney disease based on that ACR result. The National Kidney Foundation has been working with laboratories to get these 2 tests included as one test, as a kidney profile. And we have been working with labs in Michigan and continue to do so to get this more standardized, just to simplify the ordering process. How do you diagnose CKD? The criteria for diagnosis is that there has to be abnormalities of either kidney structure or function for at least 3 months. So that can be the eGFR, low eGFR below 60 milliliters per minute for at least 3 months, or other markers of kidney damage. And this map is called a heat map. It was developed to really assess not only the diagnosis, which is over here based on the eGFR levels, but also kind of assessing the overall risk of progression. So that takes into account that UACR test result, whether or not there's protein spilling into the urine. So it kind of goes from green to yellow to red to indicate the level of risk and progression. So in the more red areas is when you would be referring to nephrology and getting consultation with them. In the yellow is kind of where you're going to do those more intermediate steps of trying to prevent the progression of kidney disease. So we ask the providers screen at-risk patients, so any patients with diabetes or hypertension, and very important is the step of adding the diagnosis to the patient chart and then stratifying the treatment plan based on their stage of CKD. This is the HEDIS measure that was developed and adopted in 2020 by the NCQA. And basically you're looking at which patients have had both of the tests within a 12-month period divided by the patients who have a diagnosis of diabetes who were seen that year. And then I wanted to share just the most recent, the baseline result of this was about 30.6% when it was measured for the Medicaid MCOs was about 30%. So you can see we're still underdiagnosing, but working on it. I think it's important to mention the risk if you have an elevated eGFR and ACR of how much that can actually predict your cardiovascular mortality. This is important because oftentimes with the cardiovascular risk tools, they're not factoring in kidney disease or eGFR. So please keep that in mind for your patients with chronic kidney disease. So these are the goals when we're caring for people who already have a diagnosis of CKD. We're focused on slowing the decline of kidney function. And how we do that is, one, by controlling the blood pressure and blood sugar levels. So, you know, your basic diabetes management, hypertension control, all of that is incredibly important for maintaining the health of your kidneys. Using ACEs or ARB treatments. And there are also other medications in certain scenarios for patients with diabetes and CKD, for example, SGLT2s and GLP-1s, which I'm not going to go into a ton of information right now on the treatment. I really want to focus mainly on the screening side because that's really the first step that as a system we need to be getting in place in order to control CKD. There are modifiable risk factors, of course, like smoking, increasing exercise, reducing weight, and lowering cholesterol. And then we also want to make sure that we're detecting and managing any of the complications that can come from CKD. So that includes anemia, bone disorders, metabolic acidosis, and high potassium levels. And then referring when appropriate to nephrology to kind of co-manage patients who are at greatest risk. This slide shows a study of providers who are really paying attention, doing the appropriate testing, and then diagnosing accurately, that they actually improve their management of CKD. So they're doing a better job at providing those ACEs and ARB treatments and referring to nephrology when appropriate, and also reducing the use of NSAIDs for those patients. The Indian Health Service has done a very interesting job. You can see that Native Americans have the greatest risk for diabetes, yet they have been able to reduce the rate of kidney failure over time. And this is really thanks to some efforts that they made in quality improvement efforts that focus both on CKD screening and diabetes management together. And that includes focusing on socioeconomic barriers. So for example, getting access to transportation to bring patients into the centers, connecting them to healthy food and nutrition resources. And if you'd like to learn more about it, you can follow the links below. So even though it's, just to point out, it's an under-resourced health system, but they have had significant progress by focusing on diabetes and kidney management together. These are a couple links to patient education resources in case you're interested in sharing them. We have the National Kidney Foundation of Michigan is promoting a kidney risk quiz campaign. And this basically tracks your different risk factors, including diabetes and hypertension and age, and lets you know what your risk level is, and really to activate people to go and talk to their provider or clinician about whether or not they should be tested for kidney disease. So we have this both focused on the African-American population, the Latino population in Michigan. It's going out through social media and other platforms, and it is available if anyone would like a link to the toolkit. It's right here. We're also focused on rural populations because we find that they have higher rates of chronic kidney disease. This other resource is called the CKD heat map. It's a tool that clinicians can use to explain the two tests to their patients and then explain where the patient falls on the CKD heat map. The Kidney Foundation of Michigan is also working closely with providers, both at some federally qualified health centers and health systems, to really focus on improving the quality of screening and of managing CKD. These are a couple of really great resources on guides how to do that within the primary care setting. So if you do have questions about that, please feel free to reach out to me afterwards if that's something that your health center or health system is interested in. So the National Kidney Foundation of Michigan is really focused on improving the lives of people with kidney disease, but also looking at the prevention. So many of our programs actually focus on primary and secondary prevention of kidney disease. So that's looking at upstream factors like exercise, diet, obesity, as well as prediabetes and hypertension. I'm going to focus here on our self-management programs that may be of interest to you and the patients you serve. And we call that PATH, Personal Action Towards Health. That's the name for it in Michigan, but it's really an evidence-based program developed by Stanford University. It's a 6-week community-based workshop for individuals living with chronic health conditions. And it really gives them a lot of tools in their toolbox to manage their condition. However, it is not providing medical advice. Really, we point people back to their medical team for that part of it. So if you are interested in learning more and referring to our programs, this is a link to our website. And the CDSMP, so this is the name of the overall PATH program. There have been meta-analysis studies on the behaviors that are changed because of this program. So we have seen a significant improvement in exercise, cognitive symptom management, communicating with the care team, which is so important, having better energy, better self-rated health, and decreased number of days in the hospital. This is an overview of the 6 sessions and the types of tools and discussions that happen within that program. At every session, the patient is creating, or the participants are creating an action plan, a very specific action plan that they can follow up with the next time. And then the Kidney Foundation saw an opportunity to really focus for patients with kidney disease in particular, because there's so many particularities around managing that, around, diet and lifestyle and medications. So we did actually create 2 bonus sessions in what we call our Kidney Path program. Session 7 focuses on problems caused by kidney disease, self-management skills, medicine, and navigating the healthcare system. And then in session 8, we actually bring in a panel of healthcare professionals to answer some of the questions around that. Okay, that was a lot of information I just threw at you. We're going to take some time now for questions and answers. And I apologize, I haven't been looking at the chat, so I don't see anything come through there yet.
Thank you, Mary.
You're welcome.
Thanks, Mary. Does anyone have any questions? I know I have a few for you. I can get started. So the first question that I have is, Could you detail maybe some barriers or challenges to early detection of chronic kidney disease? Any known ones on the patient level or, provider level?
Absolutely. Yeah, on the provider level, in working with some of the health systems and provider organizations, we have found that, it's a lot to do with the processes and having things just in place to make it easier to order these things. Even the lab testing has proven to be a little difficult because it's not so standardized. I think LabCorp and Quest have done a really good job of standardizing, but in Michigan, we tend to use more local labs. So it's not always clear exactly what test to order. And I think, in the past, really the EGFR is the one test that was like recommended to be looking at this, so that urine albumin is usually the one that is missed. There can be patient barriers too. When the patient shows up to the lab, if they're not expecting to leave a urine result, they might not be able to produce that sample at the time. I'm going to let Ann Andrews chime in if she has anything else. She's my colleague with the Kidney Foundation. She's been doing this work a lot longer than I have.
Hi, I think that you captured all the barriers. I think there's among providers, like Mary said, there's just a lack of awareness about the need for the albumin to creatinine ratio. I think some providers aren't aware that you might detect kidney disease earlier with the ACR, because some have asked, why do I need to do that test if I'm already getting the GFR, since that is automatically calculated when someone gets serum creatinine. So I think the fact that just increasing awareness that you need to have both of those. The other thing is that there is the perception that there isn't anything that you can do to delay progression, and especially with some of these new medications, like Mary mentioned, the SGLT2s and the GLP-1s, those have been found to be kidney protective. So there is hope. There are interventions that can make a difference. And the earlier that a patient is made aware of it, the earlier you can start working on strategies to delay that progression.
Awesome, thank you. And I do have another question related to your chronic disease self-management program. So could you give a little bit more of a background of like how patients are referred to that program, kind of like the relationship between like providers and the National Kidney Foundation of Michigan, and then the patients involved in that program?
Sure. Ann, do you want to chime in on that? I know that
Sure.
we do have specific relationships with certain health systems. So like Henry Ford and Beaumont, they do have a way of referring kind of through their electronic health system. A lot of their providers and nephrologists are familiar with our programs. And so that is a big source of where we get some of our referrals. But people can also be referred through a number of community organizations that we partner with. For example, the Agencies on Aging are a big source of referrals as well. And then we also offer training for leaders if health systems are interested in having their own staff trained to be a leader for this. That is an option, or they can operate under, kind of our umbrella license to do that. And do you have anything to add there?
No, yeah, I think that's it. We are looking to set up processes with providers, because we do find that we are, when a provider recommends the program, patients are more likely to do that. So as Mary mentioned, we do have a referral process set up through Michigan Medicine to come directly through the EHR. And that is resulting in referrals. So,
and we do also have a mechanism to provide feedback again about, how many of those patients actually followed up and participated, how many of them completed the programs afterwards. So we can provide that back to the health systems.
Awesome, thank you. Does anyone else have any questions for Mary or Anne?
Okay, I'm just gonna pop my email into the chat in case anyone has other questions that come up later. Feel free
Okay.
to reach out. I'm happy to talk with you.
Awesome. That sounds great. So sorry, Chelsea, do you
I
have
was just
something?
gonna ask, like, Anne, Pamela, Ellen, Terry, do you guys have any experience with, addressing chronic kidney disease or diabetes in relation to chronic kidney disease at your organizations? Or is this something that you guys are looking to streamline or really focus on within your healthcare organizations?
This is Pam. I'm from Henry Ford, and we're actually very familiar with a lot of these programs and have partnered with them for a while. I just was seeing what was new.
That's great. Have you found it very helpful for your patients and for your clinicians? Or
Yes,
have any of your clinicians done any of the training, or any of your staff
yes,
done the
our people have. We actually partnered with a DPP program and actually provide them patients for them to reach out to and proactively go after people with DPP. And then several years ago, we partnered with them to make sure we were doing the screening and that too. So with the state of Michigan.
Great. Thanks for sharing.
I'm the diabetic coordinator with St. Mary's PHO and currently working on a remote patient monitoring initiative that partners with Blue Cross Blue Shield. So we're working with a small population, piloting it in 5 different clinics, mostly getting our diabetic patients that are out of control in control. But as a result of that, a lot of these patients, they haven't been seen as often as they need to. So they just need an awful lot of support. For some patients, the kidney disease question has kind of come to the front because they haven't been seen in sometimes a year, which is why their diabetes is out of control. They had a lot of life events. So I just wanted to be more familiar with some resources. The physicians, obviously at the clinics, they manage this as well as the care managers. So sending them additional resources would be of benefit.
Do you know
Yeah,
what's
we'd be
contributing
happy to provide that in addition to the information that Mary shared for that toolkit. We have some other materials, not only for physicians, but for patients about, for example, if you have chronic kidney disease, what are safe medications to take, information about nutrition, and what is kind of a kidney plate. So we'd be happy to talk with you if you wanted to follow up with Mary. We could talk about that in more detail.
Right, thank you.
Out of curiosity, what I know it sounds like there's quite a few patients who have extensive gaps between their visits with their care team. My two questions. One, what is generally, if you know, the recommended frequency that patients meet with their care team when they have chronic kidney disease? And two, do you have any idea of what is contributing to patients having these gaps in their care?
So like in the program, these patients that I'm focusing on right now have A1Cs of 10 and up. Many of the patient population, some of them are part of our rural clinic. The rest, they may be closer to city centers, but overwhelmingly large population on Medicare and Medicaid. As a result of that, they frequently have issues with transportation, issues with food security. So gaps in care usually happen because of either other chronic illnesses that they're dealing with, such as depression, or just general life events. So that would be like under the, SDOH factors. So I mean, that's the population that I'm working with. Generally speaking, diabetic patients should be seen every 6 months by their primary care physician. If they are out of control, it goes from 6 months to every 3 months. However, if they also have other chronic diseases, usually the care management team also is meeting with them in between. That has been a big focus because many of these clinics also work with MCT2D. They're in that program as well. So mostly we're focusing on diabetic patients that are out of range, but obviously once you start getting them back into care, there's a lot to get them to a point where, they're on the road to well-being and health.
Thank you for sharing those experiences. It's helpful information. Mary and Ann, in addition to the resources you guys offer and the toolkits and the patient education and staff training, do you guys connect patients or clinicians or organizations with any other resources across the state that could address any of the challenges and barriers that these patients that Ann spoke about are experiencing and contributing to their gaps of care?
Well, we have a nurse who is also living with kidney disease herself, who takes phone calls from patients and their family. And then we also have a resource navigator who can, so often what happens is someone might call and we have an emergency fund where we can provide it's not a lot of money, but it can help to bridge the gap. So $200, and they can get assistance with some kind of short-term emergency, but often there's more than just that need for $200. And so our resource navigator helps to find other resources. Sometimes it's transportation. We've had them help to get a utility bill decreased. One time we had somebody get a refrigerator. We were able to find a refrigerator for the person because they were storing their food out in the snow. Just other things like that we have been able to help with.
That's great. Thank you.
I just put that information in the chat if you need to connect patients to our patient services team.
Thank you, Mary.
Awesome. Thank you so much. Does anyone have any last questions for Mary or Ann? Thanks everyone for being here today too.
Just want to say you guys have great programs, and it's really nice to hear that there's such wonderful collaboration happening between, not only the foundation, but also the health systems across the state. And that you have things available in multiple languages. I know even if they may be limited, something is better than nothing. That's a big barrier we've seen across patient resources.
I would just add to that Mary highlighted the kidney path program, but we have other path programs. We also have a hypertension control program, which is new, and patients do receive a blood pressure cuff. So if you go to our website, you can see all the different programs that we have offered, and they are free for patients.
Great, thank you. So I can go ahead and share my screen, and we can finish up this work group a little bit early today. So let me go ahead and bring my presentation back up. Can everyone see my screen okay?
Yeah, looks great.
Okay, awesome. Well, thank you again, Mary and Ann, for taking the time to be here with us today. It was a very informative presentation, and we definitely will be sending out this recording, as well as note any of the resources in the PowerPoint that you had recommended. We'll put that in the email as well. So I just wanted to highlight some upcoming events before we close out today. So we do have a lunch and learn coming up, as well as our April work groups. So our MVC Lunch and Learn, that will be next week, March 29th from 12 to 1 p.m. You can register via the link on this screen here. And to give a little bit of background about these MVC Lunch and Learns, these sessions are really an opportunity for members to receive an overview of specific aspects of MVC's work. They are ideal for new member site coordinators, as well as any other CQI staff or collaborators interested in working together in the future with MVC. So the kickoff session on March 29th will summarize MVC's current areas of work, basics about MVC data, audience served by MVC activities, as well as ongoing partnership opportunities. For our 2 upcoming April work groups, we will have an Health and Action work group on April 5th from 1 o'clock to 2 o'clock p.m. And that will feature McLaren Flint and highlight the development and successes of their recent quality fair at McLaren Flint. We also have a chronic disease management work group on April 20th from 2 o'clock to 3 o'clock p.m. And that is going to feature Gleaners Community Food Bank and highlight how healthcare organizations can leverage partnerships with community-based organizations like Gleaners to improve health outcomes. And you can register for those work groups via the link at the bottom of this slide. So with that, thank you again to everyone who attended. Thank you to our presenters. If you have any questions, you can always reach out to us at the email listed here. Additionally, if you or someone you know may be interested in speaking at an upcoming work group, please contact the MVC engagement team via this email as well. Thank you once again for your support of MVC, and we look forward to seeing you at our future work groups. Have a great day, everyone.
Thanks, Mary.
You too. Take care.
Thank you. Bye.
Thanks a lot.